Frequency, urgency, burning dysuria. Frequency, urgency, burning dysuria. Frequency, urgency, burning dysuria. Cystitis, nephritis, cystitis, nephritis, and urethritis. Now, how do you know which one of them it's going to be? Cystitis gives you frequency, urgency, burning dysuria. Pyelonephritis gives you frequency, urgency, burning, and dysuria. And so does urethritis. Now, the difference to the first question, what's the most primal question? What's the most likely diagnosis? Is that neither cystitis nor pyelonephritis has discharge from the penis or the urethra. So if there's discharge, it's urethritis, and you answer nucleic acid amplification test and ceftriaxone azithromycin. Now, how do you tell the difference between these things as cystitis and these things as pyelonephritis? Because both give frequency, urgency, burning dysuria, and the answer is the location of the pain and the fever. If they want you to know it's cystitis, they'll tell you there's pain above your pubic area. Pubic area. Public area? Pubic area. Yes, there'll be pain above your pubic area in cystitis and not much of a fever. If they want you to know the answer, they have to tell you something. If they want you to know the answer, they have to let you know. If they want you to know it's pyelonephritis, they will tell you that the pain is in the flank or costovertebral angle tenderness. Flank or CVA tenderness. Now, cystitis, pyelonephritis, which of them gives you white cells in the urine? The answer is both of them do. Which of them gives you bacteria in the urine? Who cares? We only pay attention to bacteria in the urine if you're a pregnant woman or bacteria in the urine, pregnant, or you're going to get cystoscopy, a urinary procedure, bronchoscopy of your penis. Cystoscopy, and pregnant women, the only time we care about bacteria in the urine. Now, what about nitrites? Nitrites. I ate nitrite. Okay, I ate nitrate and I pooped nitrite. I ate nitrate and I pooped nitrite. So nitrites in the urine is a sign of gram-negative bacteria that are metabolizing the nitrate. They ate nitrate, and pooped out nitrite. It's the same thing as saying bacteriuria. And otherwise, young, healthy women, cystitis is not a sign of significant pathology. So for a woman does not need imaging. A woman does not have to have a sonogram. Men should get sonograms because men should not be having either cystitis or pyelonephritis. What do you purchase with 250,000 cases of prostate cancer a year in the country? You should purchase a life largely free of urinary tract infections, because the bacteria should not get up to the bladder or into the kidneys. So if a man has a urinary tract infection, it is much more likely that there is a stone or stricture, tumor or obstruction, stone or stricture, tumor or obstruction. If a man has pyelonephritis, it's much more likely that there's an anatomic abnormality, and that's why for men you do imaging, because you're trying to find what you have to correct. Do you have to remove that stone, dilate that stricture, biopsy that obstruction? So for men, image to find the stone or stricture, tumor or obstruction. This is a dipstick. The dipstick can tell you whether you have white cells. It can tell you if you have nitrite. It can tell you whether or not you have glucose. It can tell you if you have protein, white cells, red cells. Can it tell casts? No, you need microscopic to look for casts. So for all urinary tract infections, the urinalysis for which you're looking for white cells. The most accurate test is the urine culture, tells you the organism. But if there's no white cells in the urine, do not send the urine culture. If there's no white cells in the urine, do not send the urine culture. So what you do, it's step 3 CCS. Should I order the urinalysis and the urine culture at the same time? The answer is no. Do not order the urine culture and the urinalysis at the same time, because if you grow bacteria and there's no white cells, it's just bacteriuria. And unless you're pregnant or having urinary instrumentation, the answer is irrelevant, creates garbage data. That's not a small point for step 3. That is a general practitioner, the point that is a general family practitioner, surgeon, orthopedist, everybody, general medicine, family practice, that you know not to send a urine culture without white cells. So the sonogram is not to diagnose cystitis. I have dysuria and suprapubic pain. The sonogram is not to diagnose pyelonephritis. I have dysuria, fever, and flank pain. The sonogram is not to diagnose the urinary infection. The sonogram is to tell you the cause. Do you have something that you need to fix, or do you just have uncomplicated cystitis? Uncomplicated cystitis means no stone, no stricture, no tumor, no obstruction. Nitrofurantoin, fosfomycin, trimethoprim sulfa. If the amount of resistance in your area is low, why not a quinolone in the top 3? Because we're saving the quinolone. Like that bottle of Dom Perignon champagne you got years ago. Whether you drink or don't drink, you save it to drink it or re-gift it at some point into the future. So you save the quinolone for later. That's held in reserve. Oh, Chateauneuf de Pie, 1973. So uncomplicated cystitis is treated for 3 or 5 days. Complicated means a stone or a stricture, tumor, obstruction, and you give a longer duration. Men is always considered complicated because you should not be getting those urinary tract infections in men. And you extend the duration. Now, there's a thing about urinary tract infections. Whether it's cystitis or pyelonephritis, male or female, the most common organism is E. coli. Whether it's cystitis, prostatitis, pyelonephritis, the most common organism is E. coli. So what's the difference? Uncomplicated gets 3 days, 5 days of treatment, very short. Complicated means an anatomic abnormality, a stone or a stricture, tumor or obstruction, you go longer. Pyelonephritis, E. coli, you may get you answer intravenous therapy and go longer. Prostatitis, 4 to 6 weeks for chronic prostatitis. 4 to 6 weeks. So the basic issue is uncomplicated cystitis to complicated cystitis to pyelonephritis to prostatitis is simply an increase in the duration of therapy. Now, don't treat pregnancy unless there is, don't treat the bacteria unless there's pregnancy or instrumentation. And then you give antibiotics. Is trimethoprim sulfa safe in pregnancy? Yes, but not in the last 2 weeks. We don't like to give trimethoprim sulfa in the last 2 weeks. Are quinolones safe in pregnancy? No. Is nitrofurantoin safe in pregnancy? Yes. So pyelonephritis, dysuria, and flank pain, tenderness, and more likely to have fever because it's more severe disease. The best initial test is a urinalysis looking for white cells. The most accurate test is a urine culture if there's white cells. Do you do blood cultures? Yes, if it's a CCS case, you'll also do blood cultures. And the organism is the same. Oh, look at that. There it is. That's the pyelonephritis, yes. That's pyelonephritis. Urinalysis for white cells. And if there's white cells, you do the urine culture. Imaging to find something to correct. What's the most accurate test for nephrolithiasis? It is a CT. It is a CT, a spiral CT. A non-contrast CT is the most accurate test for nephrolithiasis. And you do this in men or complicated to exclude correctable causes, correctable things like something causing the hydronephrosis. And you might need a stent inside that ureter. So any medication, remember all the meds that we said for gram-negatives? Aminoglycosides, aztreonam, piperacillin, ticarcillin, 3rd and 4th generation cephalosporins, quinolones, carbapenems, they'll all work. We tend to use ceftriaxone first because it's easy to use. Any of them could cover it, but if you had to choose one, you'll say ceftriaxone for pyelonephritis. Now, outpatient therapy, where is the Cipro for the pyelonephritis? Because here's the interesting thing. What if the blood cultures were positive? What we know about this is if you advance the clock and it says blood cultures drawn on Monday at 9 a.m., report available Wednesday at 9 a.m. As you move past the time that the report says it's available, even if it grew bacteria in the blood, the quinolone has the same efficacy even if there's bacteremia. Inpatient, ceftriaxone. So remember, for outpatient treatment of quinolone, That's not meaning for cystitis. Don't need cystitis treatment with quinolones most of the time. Inpatient, third-generation cephalosporin, aztreonam will cover gram-negatives. Quinolones cover gram-negatives. Ampicillin, gentamicin cover gram-negatives. All of these are positive choices. All of these are good for the management. And if you had to choose one out of it, that's why ceftriaxone is at the top. Piperacillin, tazobactam, all of them, all the ones we had in the table, 4 gram-negative rods. The radiologic testing, let's see, neither cystitis or pyelonephritis, you're not diagnosing them by scanning. You're using the scan to find a correctable cause, like having to pull out the stone. Ooh, stones are small, aren't they? Yes. 90% of kidney stones that are under 5 millimeters will pass. 90% of kidney stones that are over 5 millimeters will not pass. So the urinalysis, the white cells tells you infections. What's irrelevant? Squamous cells. Squamous cells mean that you got a piece of perineum. It's garbage. Squamous cells in the urinalysis or epithelial cells in sputum are irrelevant. Now, white cells are here as a consistent feature of all the urinary tract infections. And now remember, you can't tell if it's an eosinophil or a neutrophil you can't tell if it's an eosinophil or a neutrophil just from the urinalysis. How would you tell if these were eosinophils? Ooh, allergic interstitial nephritis. How would you tell if this was interstitial nephritis? You'd have to stain it with a Wright stain or a Hansel stain. Hansel, you mean like Hansel and Gretel? Yes, Hansel like in Hansel and Gretel. Urinary dipstick to be able to tell. Blood, white cells, nitrites, protein in the urine. Oh, and that's why the dipstick will tell you if there's white cells, then you do the microscopic exam to count the number of white cells. First, you look at the dipstick, because if the dipstick is negative, you don't have to do a microscopic exam. What's the point of the dipstick? To tell you, do you need to do a microscopic exam on a slide? Nitrite is the same thing as telling you there's gram-negative bacteria. Now, protein in the urine. Do you find protein in the urine with cystitis, pyelonephritis, glomerulonephritis, or tubular diseases? The answer is protein is in all of them. But the most protein is with the glomerular diseases. So the absence of protein effectively excludes glomerular disease. The presence of protein doesn't tell you which one you have. The absence of protein excludes glomerular disease. So a perinephric abscess. Look at that. You see, there's the normal kidney. You're the good kidney. You're the bad kidney. Oh, let's see. This kidney is too swollen. So how do you know that you've got a perinephric abscess? Is a very rare disease. So how would you know to even look for it? Why would you go look for the scan? Because I just said that a scan is not necessary most of the time. So why would you do the scan? You have pyelonephritis. You get put on ceftriaxone. And how come you didn't get better? You have pyelonephritis. You get put on ampicillin, sulbactam, ceftriaxone, or aztreonam, ampicillin and gentamicin. How come you didn't get better? Because maybe you've got a collection. Why you still got a fever at a week? Now, pyelonephritis can cause fever for 2, 3, 4 days. But after 3 or 4 days, you shouldn't be having a fever. It should be sterilized. I have a wonderful CCS case. I put the person on ceftriaxone. I moved the clock forward 1 day, 2 days, 3 days. How do I know how the patient is doing? One, I can get these spontaneous nurse's notes. The other, I can do the interval history, part of the physical exam. Interval history. And in 2 minutes, advance the clock 2 minutes, it's the how you doing part of the physical exam. And it says, I still have flank pain, I still have dysuria, and most importantly, I still have a fever. Why do I still have a fever? Because I've got a collection of infected crap inside my kidney, inside my capsule. And the person remains febrile. And what's the most accurate? This is a CT, but what is the most accurate test for pyelonephritis? Or perinephric abscess, What's the most accurate test for perinephric abscess? It must be a biopsy. It must be a biopsy because this is infectious diseases. And in infectious diseases, the radiologic test is never the most accurate test. Woo! The radiologic test is never the most accurate test. Aha! The radiologic test is never the most accurate test in pyelonephritis or in perinephric abscess or in infectious diseases in general. So the only way you can tell what it is in the guide therapy is to do a biopsy because it grew, it developed, it happened, it worsened while on antibiotics. So just saying I'll give prolonged antibiotics is not going to solve it because it happened while you were on antibiotics, which implies it's an organism resistant to what you are on. Biopsy, treat what you find, drain. Prostatitis. This man looks uncomfortable. Prostatitis. Dysuria, frequency, urgency, burning dysuria. What's the difference? What's the key element to answering the diagnosis? And the answer is, what will tell you the diagnosis is it's pain in your perineal area. And in addition to that, there is tenderness of the prostate. How will you know which one it is? If they want you to know the answer, they have to tell you something. Your prostate is tender, soft, mushy, like a bruised apple. Your prostate should be firm and crunchy, like a nice fresh apple. But when it's soft and mushy, your prostate is bruised, like prostatitis. And so what happens is that little prostate becomes all inflamed and red. Look at that hot, red, inflamed rubor dolor calor tumor, rubor dolor calor tumor. And you do the urinalysis and the urine culture after massaging the prostate. So the urinalysis with white cells, but the most accurate is white cells and a culture after pressing on that prostate. Now, it's not the organism that's different, it's still E. coli. So the difference is the duration of therapy. If you have a prostate that's infected, you will treat it as if it is like an abscess. So it's the same antibiotics, Cipro or trimethoprim sulfa, and you just extend the duration of the therapy because it ends up being like a 6-week treatment for an abscess. So what's the major difference? Oh, look at this. The organism is E. coli. Look at this. Quinolones, Bactrim, trimethoprim sulfa, fosfomycin, nitrofurantoin. They all can be used. The only difference is you extend the length of therapy to treat it like an abscess. That's right.